name is Miquel Camafort. I am from Barcelona, Spain. I am working at the University Hospital Clinic at the University of Barcelona at the unit of hypertension and also at the heart failure unit. And I am participating at the meeting from the International Society of Hypertension and European Society of Hypertension that goes virtual this year, 2021. This is a very interesting question because we got many data on hypertensive patients, and many data on patients with renal failure and other diseases like, for example, a stroke. But the data on heart failure are very small. There is some Indian study with advanced heart failure patients with reduced ejection fraction that had shown that low blood pressure is associated with worse prognostic, but there are not so many data. And as it comes for heart failure with preserved ejection fraction, we have only 3 studies published, 2 in Japan and 1 is our study that will go on the journal in the next weeks. And these are studies that are showing us that patients have advanced vascular disease, and therefore they have abnormal blood pressure pattern through ABPM, and that could cause a worse outcome. But at the moment, there is many data lacking on how ABPM could be useful for heart failure. That is a very interesting question, and therefore we are starting a study, an international study that will go to see how ambulatory blood pressure measurement could affect the outcomes and the prognostic of heart failure patients. And this study will see not only on ABPM measurement, then also on other factors as comorbidity, as for example frailty, because in some countries of the world, heart failure patients are very old patients, and we have to see other factors that are related to blood pressure. From the data that we got at this moment, we can consider that maybe those patients with an abnormal blood pressure pattern, that means with rising night pattern or blood pressure non-dipping pattern, have a worse outcome. But the problem is when it comes to treatment, because we have no treatment that could change this situation, that only identifies patients with worse outcomes. That is another very good question. The data that we got until now are very different when it comes to incident heart failure, to new heart failure. There is a very interesting paper published last week on hypertension. It is available online, not on print. And this paper says that if you are looking for preventing heart failure, the lower you were, the best you do. So, for example, a blood pressure below 120 is much better than a lower blood pressure below 140. This data come from the SPRINT trial. And so what we got is that in preventing heart failure, low blood pressure is good. But data from some registries and from some post-hoc analysis from trials show that there is a G-curve. So if you are below 105 in the most studies, you go worse and you have more mortality and more hospitalizations. But on the other side, if you are on high blood pressure, you also get a worse outcome. The problem is which is the best goal for you with heart failure to be on blood pressure. We don't know exactly which are the best values for a patient with heart failure. We should go on first of all to categorize patients, because patients with heart failure have very different backgrounds. And for example, in our country, the mean age of patients with heart failure are about 80 years. So the first thing what we do is to categorize if we can go lower as possible or not, okay? And then what we do on these patients is to start to lowering blood pressure and to have the blood pressure as low as possible, but without getting too low as, for example, 105. In the case of frail patients, we are more conservative, and what we do is to start with blood pressure lowering treatment, but having the patients monitored to avoid adverse effects. If you start on heart failure on a hypertensive patient, we will maintain beta blockers if there is some other condition that requires beta blockers. For example, if you have a ischemic heart disease, you need beta blockers. If you are on atrial fibrillation with ventricular rate that is high, you need beta blockers. But it is not essential for the treatment of heart failure with preserved ejection fraction, but it is essential for treatment of heart failure with reduced ejection fraction. Other treatment depends on the availability of new drugs, like for example ARNI, sacubitril valsartan, has shown to be better than ACE inhibitors or ARBs, or anti-angiotensin receptor blockers. So the current situation is that if you are on ARBs or on ACE inhibitors and you have reduced ejection fraction, maybe if you're available to do it, you should change to ARNIs, to sacubitril valsartan, because you have a 20% reduction on mortality and on hospitalization. But as said, it depends on the availability of the drugs in your own country. And the other things is diuretics. As for diuretics, they are to be maintained if you are on congestion, but they can be withdrawn if you have no congestion. And the principal main treatment for patients with heart failure is aldosterone inhibitors, because we know on HFrEF that these drugs are causing a better outcome without so much hospitalization. And the data from TOPCAT-HF are not so clear for patients with preserved ejection fraction, but we know that on those patients maybe we have a good treatment to low blood pressure, causing maybe some lower hospitalization rate. We use this combination, for example, in patients with heart failure. I use it in my own clinic because, for example, in the scenario of HFpEF, there is above 35 to 40%, around 35-40% of patients with heart failure and atrial fibrillation. So I have to control blood pressure and I have to control ventricular rate. So this is an ideal combination to use on those patients. And in the scenario of HFrEF, as the European Society of Cardiology, and that has not changed until yet, guidelines said you have to start with beta blockers and ARBs or ACE inhibitors. So you can start on that. And the same, of course, totally for patients that are using ARNIs and beta blockers.